Welcome back to the deep dive. Today we are doing something a little different. Usually, we're tearing apart a best-selling book or analyzing some sweeping economic theory that changes how you see the world.
Right, the big macro stuff.
Exactly. But today we're going micro. We are looking at a process that is intensely personal yet completely industrial. We are talking about the hidden choreography of the hospital visit.
One of those experiences that pretty much everyone has eventually, right?
Oh, absolutely.
But nobody really pays attention to the mechanics of it while it's happening. You're usually too anxious or too groggy or just too uncomfortable to notice the system actually at work.
Yeah, exactly. You walk in, you wear the drafty gown, you wake up, you go home. It feels like a black box.
Right.
You put yourself in, and hopefully a fixed version of you comes out. But we have a source today that cracks that box wide open.
And it's a very specific source, too.
It is. We are analyzing a piece of video documentation titled HCC 1475 15 Patient Intake and Discharge. It comes to us from the YouTube channel of Gautamukala S. Raju.
And to be clear, for everyone listening, it's not a dramatic TV show recreation. It's not Grey's Anatomy.
No soaring background music here.
Right. This is a technical step-by-step walkthrough of a specific protocol used for endoscopy and colonoscopy patients. It's the raw footage of the workflow.
And there's a critical piece of context here that transforms how we view this footage. We aren't just looking at a standard Tuesday in 2025. This protocol documents a workflow from December 2020.
That date is the key. December 2020. Think back to where we were. We were right in the thick of the pandemic, pre-vaccine for most of the population.
Right.
Hospitals were fortresses. So what we are analyzing here is a hospital system operating under maximum security conditions. It's effectively a stress test for patient safety.
So our mission today is to deconstruct this choreography. We want to take you from the front desk to the curb and show you why the things that annoy us as patients, the repetitive questions, the endless forms, the waiting, are actually sophisticated safety mechanisms.
Exactly. It's about reframing red tape as a safety net.
Let's start at the perimeter. The fortress at the front desk. In a normal world, or maybe a pre-2020 world, you walk up to reception, say hi, maybe grab a magazine and sit down.
Yeah, casual.
But the source material describes a much more rigid entry.
It really creates a biological firewall. In this specific protocol, you don't even get to the reception desk without passing a screening.
Wow.
They are checking for exposure, symptoms, travel history, the standard 2020 playbook, but applied incredibly strictly.
And there was a hard gatekeeping rule mentioned in the source regarding testing. You couldn't just say, I feel fine and breeze through.
No, absolutely not. The protocol demanded a COVID-19 PCR test 48 to 72 hours before the scheduled procedure.
That's a tight window.
It is. And crucially, that negative result had to be on file. If the system didn't see a negative flag attached to your record, you weren't crossing the threshold.
It's a logistical heavy lift when you think about it, coordinating testing for every single patient 3 days out. But it highlights that the hospital's first duty is to the herd protecting the staff and the other vulnerable patients inside.
Precisely. It sets the stage that this is a highly controlled environment, but let's assume you pass that gauntlet. You are healthy, you are negative, and you are standing at the desk.
Now begins the administrative ritual that drives everyone crazy, the verification of identity.
Yes.
The big three: name, date of birth, medical record number, or MRN.
The holy trinity of patient safety.
But play devil's advocate for me here. I handed the receptionist my driver's license. It has my photo, my name, and my birthday right there.
Right.
Why does the source emphasize verbally confirming these details and checking the MRN so aggressively? Why do I have to say it out loud if they are literally holding my ID?
Because name and birthday are not unique identifiers. In a massive hospital system, you might have 3 John Smiths. You might even have 2 John Smiths born in 1965.
Oh, wow. I didn't think of that.
If you rely on just those 2 data points, you are courting disaster. You do not want the colonoscopy meant for John Smith A given to John Smith B.
That is a terrifying thought. So the MRN is the tiebreaker.
The MRN is the singular source of truth. It is a unique string of numbers generated by the system that exists only for you.
Okay.
By anchoring the check-in process to the MRN immediately, the receptionist is ensuring that every subsequent action, every lab label, every medication order, every note is attached to the correct digital avatar of the patient.
The source also touches on financial clearance at this stage, checking insurance validity, which feels like a total buzzkill, but I assume that's also a form of administrative safety.
It is. It prevents the procedure cancel nightmare. You don't want a patient prepped, IV in arm, gown on, only to find out the authorization didn't go through.
That would be, oh.
That's a failure of process. So they front-load that check to ensure that once you go back, you are staying back.
Okay, so we are legally and financially cleared. Now comes the handoff. The source describes a nurse coming to the waiting area to collect the patient. And this feels like the first real transition.
It is.
You stop being a person waiting and become a patient under care.
That's the exact psychological shift. You are entering the clinical zone. And the first thing that happens is data collection.
The source lists the vitals, weight, temperature, blood pressure, pulse, standard stuff. But then we get to the depersonalization.
The stripping away of the outside world.
Literally.
Yeah.
The patient has to remove street clothes and jewelry and change into the hospital gown. Now, the source video was incredibly specific about what happens to the clothes. They don't just toss them on a chair or shove them in a locker.
This is one of those details that separates a good workflow from a chaotic one. The belongings bag.
It seems so trivial. It's just a plastic bag.
It seems trivial until you lose your glasses or your dentures or your phone. The source specifies that all personal items go into a dedicated patient belongings bag, and that bag is meticulously labeled.
Let me guess. The big three.
You got it. Name, MRN, date of birth.
It's relentless.
It has to be.
Yeah.
Think about the chain of custody. You are about to be sedated. You cannot watch your stuff. You are incredibly vulnerable.
Yeah, that's true.
The hospital is taking custody of your property. By tagging the bag with the MRN, they are treating your shoes with the same level of tracking rigor as your blood samples. It prevents the patient from waking up in a panic because they can't find their wallet.
And then, once you are in the gown, feeling very vulnerable, I might add, comes the moment that makes it official, the wristband ritual.
The single most critical piece of plastic in the building.
The source describes the nurse placing the ID band on the wrist, but they don't just slap it on and walk away. There is a specific interaction that happens here that I think is really interesting.
This is what we call closed-loop communication. The nurse doesn't just read the band. They ask the patient to state their name and date of birth.
So I have to say, I'm John Doe, born January 1st.
And the nurse looks at the band and confirms, I see John Doe, January 1st.
Yeah.
They are verifying that the physical tag matches the patient's cognitive reality.
That makes a lot of sense.
It ensures that the right patient is actually in the chair before a single needle touches them. It's a verbal contract.
Speaking of needles, the source mentions this is where the IV line is started for sedation, and the medical history is reviewed. Allergies, medications, the nurse acts as the intake filter.
Correct. They are building the clinical picture for the team that's about to arrive. Because remember, up until now, you haven't even seen a doctor. You've seen reception and nursing.
And that leads us to segment 3, the assembly of experts. You are sitting there, IV in your arm, wristband on, and then the specialists start rotating in. First up, according to the protocol, is the anesthesia team.
This is a crucial distinction. The person performing the procedure is not usually the person keeping you sedated. The source mentions a nurse anesthetist or anesthesiologist comes in. Their job isn't the colonoscopy. Their job is you.
They are the pilot and the doctor is the mechanic.
That's a great analogy. The anesthesia provider is doing a risk assessment. The source mentions they check the monitors and vitals, but specifically they perform an airway assessment.
What are they looking for there? Do they just look in your mouth?
It's a bit more technical than that. They need to know if this patient stops breathing, how difficult will it be to ventilate them?
Oh, all right.
They are looking at the neck thickness, the mouth opening, how far back the throat goes.
Yeah.
They are checking for loose teeth that could be dislodged. They're effectively planning for the worst-case scenario so they can prevent it entirely.
The source also mentions they might order an EKG and electrocardiogram right there in the pre-op bay.
Right. If the patient has a history of heart issues or high blood pressure, they need to see the heart's electrical rhythm before they introduce drugs that could alter it. It's all about establishing a safe baseline.
So the anesthesia team gives the thumbs up. Then finally, the main event arrives, the endoscopist, the doctor.
And even though the patient has probably seen a doctor in the clinic weeks ago or got a referral, this bedside visit is vital. The doctor reviews the indications.
But why?
Exactly. Why are we here today? Is it a screening? Is it a bleed? Is it abdominal pain? And they lay out the game plan.
I liked that term in the source, game plan. It implies strategy. It makes me feel like there's a clear roadmap.
It is strategic. The doctor explains, I'm going to navigate to this point. I'm looking for polyps. If I find one, I will remove it. It manages expectations.
Yeah.
It lets the patient know exactly what is about to happen to their body.
And this leads to the legal paperwork, informed consent, which always feels a bit grim because they have to list all the terrible things that could happen.
Which is often misunderstood. Consent isn't just a signature protection for the hospital, it's an ethical requirement.
Oh, absolutely.
The source notes that risks and benefits are discussed before the patient signs. The patient needs to know that perforation or bleeding, while rare, are possibilities. You need to willingly agree to the risk.
And they sign 2 separate forms, right? One for the procedure, one for the anesthesia.
Yes, because they are 2 separate interventions with 2 separate sets of risks. You are consenting to the scope, and you are consenting to the drugs.
Okay, so everyone has agreed. The team is assembled. The patient is ready to move from the pre-op bay to the procedure room. But wait, the source describes another stop, just when you think you're rolling.
The timeout transition.
Before the bed is even unlocked to roll down the hall, the nurse stops and confirms the name, DOB, and MRN again.
I know exactly what you're thinking. We just did this 10 minutes ago. I haven't changed my name since the last time you asked.
I am absolutely thinking that. It feels like the definition of insanity.
But look at it from a system engineering perspective. Moving a patient is a high-risk transition. You are physically moving a human from a holding zone to an active intervention zone.
Right.
In a busy hallway, beds look alike. People look alike in gowns.
So this is the firewall against a mix-up during transport.
Exactly. If the nurse grabs the wrong chart or the wrong bed, this check catches it. It's the final friction point before the patient enters the room where things actually happen.
It really drives home the idea that safety is built on redundancy. You don't trust the system to work once, you check it every single time.
Redundancy is reliability. In aviation, they check the flaps 3 times. In medicine, we check the name 3 times.
So let's talk about the procedure context briefly. The source lists a few reasons why people endure this rigorous intake process. We mentioned indications.
Sure. The source highlights a few common ones. Evaluation for GI bleeding is a big one that's urgent. Follow-up on abnormal stool testing results.
Okay.
But the most common one, and the one the source highlights regarding age, is preventive colon cancer screening.
The source notes the standard age is 50, though I know that guidance shifts sometimes.
It does, often trending younger now. But in this 2020 protocol, they highlight age 50, or earlier if there is a family history. And this is really the success story of modern gastroenterology.
How so?
By going through this entire process, doctors can find precursor lesions, polyps, and remove them before they ever turn into cancer. It's a massive return on investment for the patient.
So the procedure happens. The patient is asleep. The doctor does the work. We skip the medical details because the patient is effectively offline for that. We rejoin the workflow in the recovery phase.
The patient is wheeled back to the recovery area, but the vigilance doesn't drop off just because the scope is out.
The source emphasizes that monitoring continues. It's not nap time yet.
Vitals are watched closely. The anesthesia wears off differently for everyone. Some people wake up crisp, others are groggy or emotional. The nursing staff is monitoring for stability. Is the blood pressure holding? Is the oxygen saturation good? They are watching the landing.
And this is where the mystery is revealed. The debrief. The doctor returns.
This is a critical communication moment. The patient is awake, but they might not remember this conversation later due to the amnesia effects of the sedation. The doctor explains the findings. Everything looked good, or we took a biopsy, or we found a polyp.
Does the source mention who else hears this? Because if I'm amnesiac, telling me seems completely pointless.
Usually because of that exact amnesia effect, it's best practice to have the discharge instructions written down or shared with the escort or family member who's there to pick you up.
Which brings us to the rules of leaving. You don't just hop off the bed, high-five the nurse, and walk out. The source lists strict discharge criteria.
You must be awake, alert, and stable. But the big rule, the one that really trips people up, is the transportation requirement.
The no-drive rule.
It is non-negotiable. The source is explicit instructions are given to the patient and the family member. The patient cannot drive.
Is that just legal liability or is it biological? Because I've heard people say, oh, I feel fine, I just had a great nap.
It's purely biological. You might feel awake. You might be able to have a perfectly normal conversation.
Yeah.
But your reaction times and judgment are significantly impaired by the sedatives.
Wow.
You are effectively intoxicated. Driving would be incredibly dangerous.
So the hospital demands a responsible adult to take custody of you.
Custody is the right word. They're transferring the duty of care from the nursing staff to your family member. They give instructions on diet, start light, and activity, no heavy lifting.
And warning signs too, right? Like, if you see X, call us immediately.
Exactly. Continuity of care. The procedure isn't over just because you left the building?
And finally, the exit itself. The source describes a wheelchair assist.
Right to the car.
They don't let you walk, even if you want to stretch your legs.
No. Fall risk. You've been sedated. Your legs might be a little wobbly. The staff ensures the patient is wheeled all the way to the curb and helped into the vehicle. It prevents that last-minute slip and fall in the lobby.
It's a complete loop. From the moment you hit the COVID screen at the front door to the moment the car door closes, you are never really alone. You are held by the protocol.
That's a really beautiful way to put it.
So let's step back and look at the whole picture. We started this deep dive talking about how daunting the hospital feels, the cold bureaucracy of it, the feeling of being a cog in a machine.
And we've seen that the bureaucracy is real. The testing requirements, the triple checks of the ID, the bagging of the clothes, the consent forms. It is a lot of paper and a lot of questions.
But when you lay it out linearly like this source does, the intent completely changes. It's not checking boxes for the sake of checking boxes. It's not just to annoy you.
No, every single one of those annoyances is a barrier against error.
The redundancy of the big three name, DOB, MRN, prevents identity theft of the worst kind medical identity mix-ups.
The timeout prevents wrong site procedures. The no-drive rule prevents post-procedure accidents. The belongings bag prevents lost property.
It's a machine, yes, but it's a machine designed to compensate for human fallibility.
Hospitals are chaotic, high-pressure environments. Humans get tired. Humans get distracted. These protocols are the guardrails that keep the train on the tracks even when the driver is completely exhausted. It's a system designed to protect you from the chaos.
So the next time I'm sitting in that drafty gown and a nurse asks me for my date of birth for the 5th time in 20 minutes, I shouldn't roll my eyes.
You should say, thank you, because that question is proof that the system is actually working. It's proof that they are treating you as a unique, specific individual who deserves the exact right care.
It turns the frustration into reassurance. If they stop asking, that's when I should really worry.
Exactly. Silence is the danger. The questions are the safety.
I want to leave you with a thought to mull over today. We often judge a service by how smooth and fast it is. We like friction-free experiences. We want one-click ordering and instant streaming. But in medicine, friction is a feature, not a bug. Next time you encounter a hurdle in the hospital, a repeated question, a waiting period, a form to sign a design, ask yourself, what invisible catastrophe did that moment just prevent?
That is a very powerful question to ask.
Thanks for diving into the hidden choreography of care with us today.
Stay curious, everyone.
See you next time.